If you would, go ahead and place your name and campus in the chat. Check your screen name. Make sure that your first and last name is correct. And just as a reminder, these sessions are recorded and they are viewed by the attendance administrators. Have about 20 more seconds. All right. So welcome to week 5. Hopefully everyone is doing well. Let's see here. We're essentially almost halfway because the last week is week 12, and that's what we meet just to go over the results. The HESI is week 11. So we really are almost halfway, you all. So just be thinking about the things we need to rearrange, delete, add, and all of that, especially if you're taking more than one course. So just make sure that you're looking at your schedules. You have clinical, you have home, you have work, you have all of those different moving parts. So just make sure that you're accommodating for all the things that you're responsible for. Because to me, it just seems like it just goes faster once you take that first exam. I know it's the same time, but it seems like it just goes by pretty quicker, much quicker than it did once we started. So we do have our unit exam 2 tonight. So we will make sure that we go back up our content from last week, which was communication. And then this week is talking about the different people that are on that healthcare team and looking at delegation, but we'll capture everything. But remember that the HESI and the NCLEX is all inclusive. So go ahead and start going back, reviewing your recordings from week 1, looking at that content. And for those concepts that you are still not clear about or need some more different understanding of the game, a better understanding of, make sure that you look back at that for sure. But the HESI and the NCLEX are all inclusive, which includes everything. Really not sure, how that question or that scenario might land on that exam. So go back and make sure that you're looking at all of those concepts for each of the classes that you're actually in. So let's just do some recall of our prior knowledge. If a nurse is stealing medications, whether or not it's a Tylenol, it's narcotics, but it's not their meds, it's the patient's medications. What kind of offense is that? Is that civil or criminal?
Criminal.
Criminal.
That's criminal.
Okay. So what about if the nurse, some type of way, and it could be various scenarios, the nurse is sharing that the patient's protected health information? Is that okay? And if not, what is that called?
Hip or not okay.
It's not okay. And what is it called?
It's a HIPAA violation.
HIPAA violation. Exactly. Good, good. Okay, so who can do what? Well, is this okay? I'm just trying to throw a scenario at this. So, can the UAP measure vital signs? Unlicensed personnel, CNA, they
They
have
can
different.
take vitals.
Yes.
Yeah, they can do
Yeah, they can
vitals.
take vitals.
Yes.
Okay. Can the PN administer PO medication or IM medication?
They can, yes.
Can the unlicensed personnel interpret those blood pressure measurements that they actually got? So, for example, they took the patient's blood pressure in room 201. The blood pressure was 132 over 98. So, in addition to getting that measurement, they're interpreting and discussing information about those vital signs, that blood pressure.
No.
They
Okay.
can't.
No.
No,
Ex-
but they can
exactly.
let the nurse know
Know what
that
the
I.
measurements are. Got it. Good, good, good. Okay. So, what about if we think we don't have confirmation? There could be a pressure ulcer, like we're doing home health, and this person has developed a pressure ulcer. They have unexplained bruises. They may even have fearful demeanor. Um, and also, the patient may report that they sent the caretaker to the grocery store and they did not come back with any groceries. Therefore, they don't have anything much to eat. What do we do in that situation?
Please.
Report it. State
Okay,
board
because we're what kind of reporter?
Mandated.
Even
mandated.
To
though we
report it.
might not have all the reasons why the bruises or we might not we might can't confirm the word that they're using. We might cannot confirm the story about, the caretaker going to the grocery store. We might not have a receipt. They may have, the patient might have even eaten all the food that they actually um went and bought. We don't know, but there's suspicion, and we don't have to confirm. But because we are mandated reporters, we're obligated to report the suspicion. And even with, even if it's children, whomever, they have the protective services out there that we are to report it to. Okay. So, what about if we have we've administered a medication and we administer it incorrectly? What do we do?
Have to do an incident report.
Mm-hmm. And in some facilities, they call them different things, but essentially that's what it is. And it's just an account. They get the story, they write down everything, and then they do those incident reports. Even if a person falls, if they even do them. I've even seen facilities do them with the bruises. Anything that happens that's what we say out of the ordinary or that's not normal. We don't really say that, but they do an incident reporter. They call them, what do they call those things in other facilities? But essentially, everybody's heard of an incident report, and it's not so much so to harm the nurse, but it's to gather information so that they can, determine what happened and prevent the reoccurrence and see if anything needs to be changed up because there might be a policy or something might need to be revised. There might be an behavior or something going on that we're not aware of. Um, I think the story that the example that I gave you all a while back was, the patient is at the door and they're continuously hitting on the door saying, "Hey, let me out," especially if they're like in one of those locked units. So we want to capture the patient in room 201 stood at the door, for 5 minutes, 2 minutes, whatever time frame, capture it somewhere because there might be an incident report later on. This client has bruises, and we can kind of narrow down or have a path to how those bruises might have occurred. So, signal events. If you were going, and we're going to use a chat for this, signal events, SENTINEL, not mistake. If you were trying to explain to someone what is a signal event, paraphrase it, put a one-liner, two-liner in the chat. We'll give you a minute and or two to define that. A signal event. And send it out so everyone can see it, so we can all, look at it, and it further strengthen our understanding. An event that occurred by accident that led to harm or death. Okay, keep going. Okay, unexpected. And things that could lead to a signal event, yes, is medication error, not doing the timeout doing surgery. Good, good. A signal event is an unexpected event that results in potential or has the potential also to result in a person's death or life loss of eyesight or limb. And they do have measures in place to so these events don't happen, but they are still happening. So the policy procedures that facilities have in place, for example, the timeout, the person just left out of the room, but they come back in and say, hey, what is your name? Which extremity are we doing surgery on? It's like, it seems unnecessary, but there is happening enough because, there's this thing called human error. So we don't want to, because that patient's in immediate harm, the facilities in harm, the staff, everybody. And so we do want to take the time to follow those procedures and that they have put in place to hopefully, people that are under our care and everyone does not have surgeries and body parts removed, surgeries on body parts that are not supposed to have happened. They're not receiving medications, even questioning that order. We'll talk about that a little bit more as we review the upcoming content. If there's an unusually, because for the most part, we have what we call walking drugs, these medications, these lists that you all are familiar with, that you often see, and you've already learned the doses. And if you're seeing there's a complete order, you have all the components, but it's an unusual dose, it's given at an unusual time, it's on us to, question that order. And if we are having trouble hearing back from that healthcare provider, we might have to bring in that in our nurse manager to help assist to contact them. Because usually they always have some method of contact. And if they are like really, really off the grid, then they still have some method of being contacted. All right. So far, did pretty good. We just did some recall on our unit exam one's knowledge of concepts. Let's see, pull this up. So the information doesn't go anywhere. Just continue to build upon. Still ask those questions about the concepts that you still have, questions about. All right, so let's make sure that we go over all of our content, and then we will use some of our time to also let you all get in your week 10 group, not your other group, not just your random groups. Okay, so let me share my screen here. So active listening, and we're going to take the time to go through all of these slides. You all want to read them and talk about them, just to make sure. And those things that you still have questions about are just not clear after we discuss them. Put that on the separate list. That would be at the top of your list. Okay, here. Okay, active listening is communication, and it helps you to start to form those therapeutic relationships, which are needed for us to be assertive. But I'm not talking about being assertive. They're needed to advocate. What is advocacy for your client? Because a client, we need to understand, what our client believes, what are their goals, what's their understanding of the disease process they have, what is their understanding of the interventions that we want to implement. Is this something they even want to participate in? Is it important to them? It might not be, but that active listening, it helps to form and shaping that therapeutic relationship. Now, we're not talking about breaking the rules. We want to listen to our clients, and we're not talking about breaking any policies and procedures or practicing out of our scope. But it does help us to gain a better understanding of, hey, we might need to reinforce, reteach what we've already reinforced, because the client, still might not have an understanding. We might need to change up the language, the verbiage of it. We might need to put it, we should be talking in lay terms, because remember, the person more than likely isn't a healthcare provider. And so we do want to put those things in terms that they can understand. So key factors in active listening. The health-related reason for gathering that data or giving information, like why are we even talking to this client? Well, we're in charge of their care. We are there. The patient is getting ready to have surgery. We go in and make sure that client doesn't have any other questions or concerns, because that client, may have given consent. That client might not have given consent because they still have some questions. even though, and remember, they can always change their mind. They can be on the gurney, headed down the hall, on the elevator, and they can say, oh, change my mind. And it's okay. Do not assume accuracy of information without checking it out. Want to make sure, hey, patient, ma'am, Mr. Whom or Miss whomever, do you have any other questions? I know the doctor came in. I know his assistant came in. We know that, and they're having surgery. Everybody talks to the patient. The anesthesiologist came in, but still, do you understand the surgery? Are there any more questions? We want to clarify, just to make sure that all of the info, this client does not have any more questions, because if they still do, truly they can't give consent. But we do want to make sure they have all of the information they need in order to make an informed decision. Okay. Effective collaboration involves sharing observations and inviting input from other disciplines to optimize the client outcomes. So we're that little hub. We're like that centerpiece, even though you have physical therapists, we have the radiologists, we have all these different people on the healthcare team that are involved in this client's care. And they're needed because we're providing that unique, individualized care. We still want, after the client comes from physical therapy, or the physical therapist go into the room, or the PTA, physical therapy aide, whomever that other person is on the healthcare team, finishes whatever the care that they're providing to that client. We want to go and ask, hey, how did the patient and 201 do with you today? Were they compliant? Did they, were they non-compliant? Did they complain of pain? We want to collaborate so that we can find out, well, how did they do? Did they say that they were understanding, that they want to continue? And that helps optimize and further makes that client care individualized. That collaboration is real important. So we looked at the different listening techniques. We talked about restating. That's simply repeating what the client said. Clarifying is asking questions in response to the patient's statement. The client says, I know my head hurts when I, turn to the right. So we ask a question. You say when you turn to the right, not the left, your head hurts or your shoulder hurts. And I'm just making up something. So, and then reflecting, put it into words, the information that we receive from the client, and reflecting and paraphrasing, we're actually putting it into our own words. And then minimum encouraging, that could be using sounds, or words, go on, tell me more, to encourage the client to continue to share information. Because we want to show that client that we're invested in their care. That's the whole purpose why we're there, is to provide that best care for them. And then this one we're not too comfortable with, remaining silent. It is okay to be silent and be present, and just letting the client know that we are there for them. Summarizing, stating the main idea that we gathered. The patient has went through, is giving us their story, giving us information, and then we summarize it. We shorten it up and pull out maybe those main points. Okay, so I hear what you're saying. So 2 things I understood, 1 is, and then 2 is. So it's a summary. We don't go back. We're not repeating what they actually said in a different way. We're just pulling out those main points that's summarizing that whole conversation. And then validating allows the patient to correct any information when we summarize it. Because sometimes we, as the receiver, might misinterpret what the sender, the person that we're talking to, actually meant to say. And so validating, it allows that person, oh, what? No, that's not what I meant by that, or that's not what I said. So that validating does allow the patient to correct that information. Positive communication techniques, clarifying, being aware of our body language, leaning in with glaring eyes. We do want to make that eye contact, but not sustain and leaning in. We don't want to be, our arms fold. We're doing a dressing change, and we're making sounds and gestures and all of that, because the wound might have an odor. We want to establish eye contact, look away. We can establish eye contact again, look away. We want to keep our promises, even if it's not us that is directly For example, client, the water pitcher, the room in room 201, they want their water, their ice refreshed. And so if we say that we're going to get that water pitcher with refreshed ice back to them, even if we can't take it back, we can delegate someone to take that back. So just keep the promises. And then also using those I messages. It is less offensive. So here we go. So just so we have positive, we have negative communication as well. The one that we don't really think of as these two right here, false reassurances. Patients going down for surgery and we say, oh, everything's going to be okay. Doctor so-and-so has done this surgery many a times. Everybody's been fine. We don't want to make comments like that. We hope everything is going to be fine, but we really don't know that. And so we don't want to give those false reassurances. And then if we know it, and this is our opportunity to also ask the client, do they have any questions? Do they need more information about whatever it is, the intervention, the treatment, or whatever it is that they're getting ready to do, or that you all are talking about? Giving advice, because you are that trusted. I think we're how many years in a row nurses are that trusted profession. And it's not that the client's trying to trick you or anything, but they really, because you have established that therapeutic relationship, you're showing that client that you have their best interests at heart. You're being assertive, you're being honest, respectful, you're telling them the truth. You are letting them know, hey, I have to come in here at a minimum of every 2 hours to check on you. I may come a little bit more. You're letting them know, hey, the policy is, we are supposed to, at a minimum, turn and reposition you every 2 hours. Whatever it is, that information that you're giving them, you're being honest about it. So you've established that therapeutic relationship. So they trust you. So they ask you, hey, would you let Dr. So-and-so do this surgery? Would you take this medication? Or would you accept this treatment? So, but we give it back to them. We say, hey, now if you need more information, we can get you more information. But we want for you to make that decision. And we're going to support you in that because I am your advocate. Okay. So SBAR, what is it? It is a way that helps us to communicate. It's situation, background, has several components, assessment, and recommendation. Now, some people will, I think maybe in Jerry, you all have seen the I before the S because, you state your name, the nurse's name, but it's part of the situation still. We tell them who we are and what patient that we are actually calling about or discussing. So the Institutes of Medicine recommends training health professionals to use practices and tools that support effective communication. And SBAR is one of them. One such tool consists of accurate communication between professionals and it's the situation, background assessment, and recommendation. This is a common communication technique. And it's so structured that each component does not, once you put it all together, whether or not we're handing off, you're going home and I'm coming on to take care of that patient, or if we're calling a healthcare professional. SBAR keeps us structured and aligned, and it helps us to assist with that effective communication. Okay. So situation. This slide right here looks at it when we're talking to the healthcare professional. What is the reason for the call? What is our why? We do want to include our name, the unit, patient name, and the problem. Okay. Then background, why were they admitted? What was the date of admission? Current status information. You want to have, you want to have current vital signs, but you also may want to have the previous set just so if they need to, for comparison. What medications are their own? Allergies, IV fluids, and their cold status. And usually all of this is on those physicians' orders. All this is like a one pager, even if it's a continuous page. Generally, all this information is in the same place, and that's on the doctor's orders. Now, make sure that you're including. Let's go back to situations. Some patients, you'll be surprised how many patients actually have the same first and last name. So make sure that you're getting. Some will even ask, well, what is their date of birth or what is their age? So date of birth, so they can calculate their age, just to make sure that they have it correct in their minds who that patient is. Because a lot of times when you're making this call, are communicating with the healthcare professional, the doctor is not right there. So they are literally basing their recommendations or their next orders or our next steps for that client based on what you are telling them. So you're the eyes and the ears for them. So for assessment, what you think is going on based on the data findings. And then, of course, we're collaborating with the RN as needed. Do we think this is life threatening? What are those assessment findings? So we do know, so can the RN and the LPN do assessments? Can the RN and LPN do assessment?
RN
LPN can't do
do
the
the
initial
assessment, the
assessment,
initial,
right?
and the LPN reassess.
Okay. And then give me some both. That's correct. What's some more information about that assessment that the RN versus the LPN? What's another word that they use? So while we do assessments as PNs, is not as complete or comprehensive as the RN assessment is. But you all are correct. They do that initial assessment. We come in and do the follow. We do assessments thereafter, and then plus as the PN, our assessments are not as in depth. So the RN does that complete admission assessment. Okay. All right. So this slide looks at two nurses. One's going home, and the other one's coming on. So again, SBAR is still there to help us to communicate in a structured way so that we don't forget anything. Mission date, chief complaint, and diagnosis. Usually you all will know each other unless, you might be one of those, new persons or someone that doesn't just work at that facility often. So of course you would tell who you are. Background information, medical history, allergies, their code status. Again, all of that information will more than likely be on the MARs. Now, lab results might not be on the MARs. You may have to actually go to another tab in that medical record. But a lot of facilities print out what they call cardexes, and they may call them different things in other facilities, but it's like a quick overview that really matches his SBAR. It kind of, what they do is they go in and they set up the cardex. So when the cardex is print out, we use them to get report, and we can add any other information, but they most likely, the ones I've seen, they have most of these things already clicked. So when they print out or they appear on our screen, they really have all of this information there. So their medical history, their allergies, their code status, lab results, location of IV lines, diet, their mobility, any pain management strategies. And then you do know, I don't know if you all have seen on your MARs, if you administer as needed a PRN medication, there is a follow-up. So that nurse, if the follow-up isn't required prior to you leaving, that nurse will also need to know to follow up. But a lot of times, depends on how it's in the actually entering the system, it'll automatically pop up. But some systems I've seen, you have to actually go in and know to follow up on it. So we administer Tylenol at 2 o'clock, and our shift is changing at 3. And then within that 4-hour time frame, 4 or 6 hours, the next person should go in and document. Some electronic systems, they have it set that it automatically pops up, and some the nurse has to go in and actually document on it. So, and then any responses to the interventions that we've done, that shift. The person has had a fever. We've administered Tylenol once. The temperature has dropped, but they're still, they're still febrile. And so just any responses. Patient is complaining of pain, we administered whatever it was around maybe 2 o'clock. The patient still rates their pain as a 7. They're saying that it hasn't changed. The next pain medication is due at, in an hour, just making up little scenarios. So here, assessment, vital signs too. You might want to also have the last 2 just to show that trend. Did the person have the EKG done? Did they have a chest x-ray done? Any diagnostic studies? Any medications that were prescribed? And then, of course, we always want to keep our clients safe. Are they at fall risk? Patient in room 201, they don't use their call light. They keep getting up without assistance. They're walking around in the room without their assistive device. but the cane, walker, crutch, whatever it is in reach. So we just need to bring that to the attention of the nurse that's taking care of this client. And then recommendations. What are the goals of the care? What needs to be done? Education and discharging. I want to pause right here, make sure I'm not missing any questions in the chat. Okay, not seeing any. We'll keep moving. Okay, so conflict resolution. Conflict is just a natural part of life. I mean, there's different degrees of conflict, but just because a person might not know or understand what are the expectations, they might not. There may be a knowledge barrier. It might just be because that person is just they may understand, but there's still an issue with whatever the answer is, or whatever the intervention is, or whatever the procedure is. So all that to say that conflict is just a natural part of life. Temper our own attitudes and behaviors. We do want to do that. We don't want to come off as passive or aggressive. Passive, we're just passing the buck. We're not tending to the need of the client. And aggressive, it's demeaning, it's disrespectful, and it's almost like a threat to the client. So we do want to just make sure our own attitudes and behaviors are tempered. Be aware of our own initial reactions. Take a deep breath, blow out the candle, say count to 10. We all have these different techniques that we can use because there are some things that will come up. And but take the time to think critically. Think critically. Think about all the components. So you get the information, tell the person, okay, I'll be with you in just a moment, because you do need to take that time to think critically. Treat the conflict as an opportunity to voice our own opinion and listen to the other side of the story as well. So I know that a lot of times they're just trying to get you in the facility, get you started, but they do have these committees that you can work on. Ethics committee, it's conflict resolution probably is part of the ethics committee. And so this might be an opportunity to work on a committee at the facility that you're working at. And just know that you're going to have to listen to the other side of the story. Not only listen to it, they have usually to put things in writing. And they have these statement forms that they have to write it out. Rarely do they record people. Choose your approach. A win-lose approach will only escalate the intensity of the feelings involved. We do want, now it's on the other person to receive that you're listening to them and the solution, but still we don't want to escalate it. Listen and learn. Conflicts are often based on assumptions and lack of information. Usually it's bits and pieces of some information that is missing or have been overlooked, or the person just didn't understand. Discover what is important. What is that core issue? Because and several times a person may be voicing that is this, but it's really something else. That the issue really is. What is that core issue? Respect one another. A scenario could be that we have a family member of a patient. They are saying that their loved one care is not being provided appropriately for them. But the core issue, after we sit down and talk to the person, the family member may break down and say, hey, I really struggle with placing my loved one in this facility. And so they feel guilty about having their loved one there. So, then that's the core issue. Well, let's see what resources we can get you. What is the options for this client to return home? Are there any resources, that can come in and assist? Or is this the best place? Should this be a continued conversation so that, we might have to connect them with social services or a social worker, just so that they can, or a person of faith, because they do have, a lot of facilities do have those persons on staff, so that their loved one can talk through their issue with, their loved one having to be in a facility or in, the status that they're in. because it is their loved one. They do want the best for them, and then for the most part, the loved one, wants to be able to provide everything for their own loved one. And so it's not like that they dislike us, but that's how it comes out as conflict. And so, but after you sit down, the core issue is they feel that they have failed their loved one. So respect one another. Conflict can be very emotional. Stay away from name calling and blaming. Find the common ground to create the highest common denominator. Okay. So we do know that this script right here, it does help with communication in the workplace. So again, just laying out the facts, staying away from what ifs and information that's not factual. We wouldn't probably need to pull up the policy procedure just to make sure that what we're talking about is really the issue, and we're saying what really should have actually happened. So this, and then be open to the other person describing how they feel. So describing the specific situation of the behavior. So allow the person to state their concerns, even if we find out that their concerns have nothing to do with the issue that initially was voiced. But then we want to, there are many times, there are usually always alternatives to, assisting and seeking out an agreement. There's usually always, hopefully, we find some kind of common ground. And then we do want the consequences, we want to make sure that there's an established team goal. And then, so this is just, one way of helping people to talk through and communicate effectively. That's all that this is. So the chain of command, I know you all have probably, once you've been inside your facilities, you've seen, probably been introduced to the CNOs, the DNOs, the assistant DUNs, the ADUNs, and all that. Even on your campuses, you have, DUNs and ADUNs. And so, under rules of assertiveness, always go to the source. Follow the chain of command to resolve your concerns. The client's safety is priority, and the nurse must activate the chain of command to assist in resolving that issue. That's what I spoke about early on. We have contacted a healthcare provider. We notice an order. The order has all the components, but we notice that this is an unusually high dose. This dose is high or low, but it's an unusual dose. So we contact the healthcare provider. We're ready. We got the situation. The reason we're calling is because we're questioning this order. We give all the information, and we have the SBAR information in order to contact the healthcare provider, but the healthcare provider is not responding to us. We've been asked to page, we've been asked to call, leave a message. They have different ways. They even, like I said, they still have pagers. But we've done what is required, but we are not getting a response. We must then activate the chain of command. We have to call in maybe our charge nurse, the clinical supervisor, the nurse manager, whomever, the department head, to help resolve the issue. Okay. So let's see. I think I have some examples here. Did I give you all examples last time? We're just going to talk through these. So which of the three are a statement of the facts? Or the person is being factual and they're being respectful. Which one is that?
Assertive.
Assertive.
Okay. Is this an example of being assertive? Ma'am or sir, we have to come in at a minimum of every 2 hours to check on you. Is that an example of being assertive?
Assertive.
Okay.
Yeah.
Ma'am or sir, we have to write down what your intake is after, with each meal. What is that? Aggressive?
Is that still assertive?
It's still assertive, exactly. Because remember, we just said communicating statement facts in a respectful manner. Sometimes our clients, they don't want us coming in bothering every 2 hours, but remember, we're not changing the rules. We're being honest, we're being respectful at a minimum manner. So we must come in, and we have to write down what you've eaten. We have to calculate your intake, um, intake and output. We have to, at a minimum, come in and check on you, even if it's during the night hours. So we're being respectful. We're telling them, stating what the facts are. And then the other piece of it is we're standing for the patient's rights without violating the rights of others. Let's see. I thought I went in more detail on the next slide. I think there was a different PowerPoint I had. Okay, so what is aggressive? So I gave you a definition. You picked it out. So now this time I'm going to ask you, define aggressive. It's the opposite. Define aggressive.
You disrespecting the patient.
Mm-hmm.
You're not paying attention. You basically disrespecting them.
Okay. And that also includes belittling, making fun of, uh, and it's a barrier to communication. So if we go in and we're being aggressive with the client is not going to want, if even if they were in pain or they had an issue, they more than likely going to be afraid of or not tell us information. So it is actually a barrier to communication. The person will feel unsafe. And it's also the same thing with passive. It's a barrier to communication as well. Every time I tell, nurse George or Lisa, we pick on George and Lisa, they just tell me that the next person will do it. They pass the task on. They neither ever completes the task or complete what is being asked to be done. And it is a form of being dishonest. Effective communication can resolve conflict resolution. So we go ahead up front and say, hey, this pain medication, the doctor has it every 4 hours. In the event that you need it before the every 4 hours, we will have to actually call the doctor. But right now, this is the only medication that you have. So that in itself can resolve or even prevent conflict resolution because this patient might be, used to at home. They just take a pill whenever they got ready to. They probably didn't even realize that it said every 4 hours on or however many hours on the medication label. But listening and discussing privately whatever the issue will is not a barrier to communication. And it helps us again to strengthen that therapeutic relationship with our clients. So effective communication can resolve and also pretty much prevent conflict resolution. Conflict. It can effective communication can help us resolve conflict. Listening and discussing privately. Because just think about it, if you have an issue, you would want, even if that person is in a semi-private room, we can lower our voice tone. If the patient is mobile, we can ask the client to go to the sitting area, that's private, or most facilities have a place where you can go and speak to the clients, but making sure that is that we discuss it, just hearing them out because there could be some misunderstandings. They might not understand, just like the pain medication. They might have never understood that it wasn't supposed to be, you have to give it a certain amount of time to see if it actually works. But then, on the other hand, you've given it that time. We might have to make that phone call. The client, pain could be getting worse. We reassess and we report those new findings. Okay. So passive and aggressive, they are barriers to communication. Passive, we're not completing the task. Aggressive, we're being disrespectful, and the person will feel unsafe. Assertive, we are being honest. We're stating, whatever it is that's supposed to take place. Examples that I gave was, we're at a minimum, we're gonna have to come in and just check on you. We might have to talk to you every time, but we need to, look at your, make sure your chest is rising up and making sure that you're okay, without violating the rights of others. Okay. So let's get ready to talk about the ones that are on the healthcare team. So groups of professionals who contribute to care and treatment of the client. And there are so many. I actually had a little list here. Now, I'm gonna do like a pre test here. The dietitian. What does the dietitian do? And you can come off mute and tell me what's your understanding of what the dietitian does.
A person that provides adequate nutrition for a patient.
Okay, one other person. What does a dietitian, what part do they play?
Um, they organize the diet of the patients.
Okay. So hopefully they have put together, because you ever thought about, or have you ever seen like the menu for like the day and the menu for the next day? And the means like, wait a minute, you never thought about like who puts that all together? You know, why did they pick green beans and mashed potatoes and they had this type of meat? And I don't know if you ever really thought about that, but yeah, so that dietitian, they're supposed to look at the balance. Remember my plate, and George at least we talk about my plate, a nice balanced diet that has all of it, that includes all of the different food groups, and hopefully also appeals to the person's appetite. And also supportive of if a person has a wound, that's supportive of wound healing, that's supportive of that client just getting better overall. So that dietitian plays a huge part in making sure that, because they don't just haphazardly just say, oh, okay, we're going to eat, today's menu is going to have, and then not only that, they also have an alternate. So they have a whatever the main choice is that everyone more than likely will get. But then if someone have dietary restrictions, they can't eat green beans. But the green beans counts as their vegetable for that meal. They have to also have an alternate that's readily available that will take the place of in nutritional value, that's appealing to the appetite, and also that will support wound healing or nutrition if needed. So the dietitian plays a huge part in um, taking care of that client. There's so many of us on the healthcare team. What about the surgeon? What do they do? What does a surgeon do?
The surgeon is the one that take care of the patient and look over, make sure if they have to have surgery, they don't want to look at the gallbladder, etc.
Okay.
Making sure everything going from a surgical standpoint.
Okay. So whatever that body part is that they're doing surgery on, whether or not it's removal or repair, that surgeon performs the surgery. You're right, Ms. Dunn. Thank you. And then so also they place orders too. They may order pain medication. They may order other different types of meds. Like if they lost, a substantial amount of blood, they may order, for packed red blood cells to be given. If they notice that the patient had a drop in sodium, and I'm just making up different things during the surgery, the whole point is they may also place or give orders for medications, IV fluids, wound care, and things like that, in addition to performing the surgery. Okay. So what about the pharmacist? What does the pharmacist do?
Help with the doctor prescriptions, filling orders for medication that the patient needs.
Okay. Unfortunately, though, if we give it and it's the wrong thing that they put together, it's on us. But yes, so the pharmacists, they're licensed to prepare, to compound, because sometimes there's medications that have to be put together or compound and dispense those medications for us to give. And so that's that pharmacist. And then like we see now where they can, if their patients like, discharge home, they go pick up those meds, the pharmacist can also do like a consult, do some health teaching. They can do health teaching as well, but they're licensed to prepare, compound, and dispense medications. So what about x-ray technician? What do they do?
Provide images for different procedures or requests from doctors for different body parts to see.
So they actually capture the images exactly. So they go in, they perform the x-rays or whatever those different procedures are. X-rays, some do a little bit more than x-rays, but at a minimum, they perform those x-rays, which are images of whatever that body part is that they want. Excuse me. Now, some like ultrasounds and things like that, they might have to bring in a different technician to actually do those. But at a minimum, the x-ray technician, they can perform those x-rays, and that is where they're capturing that image of whatever that body part is. Not sure what's going on with my throat, you all. So the physical therapist, what is their what do they do? Physical therapist.
They provide therapy for the patient, like if they had surgery, they get them up and walk them, or they do range of motions or whatever they need to get them back to where they been baseline.
At least back to, hopefully back to baseline, or as close as to baseline, or optimal, whatever those words you want to use. So yeah, so they help restore that function, and hopefully prevent the development of complications, and then help them to regain that mobility safe. Because think about it, a person just had surgery, even if they had just had a fall, um, a lot of times that person will be afraid, they're in pain if they just had surgery. They're not wanting to move. If they fall, and they may be afraid to, do that, stand on their own. And so we have to think about too, restoring that function, but also preventing the development of complications. Um, so that is good. And then, like I said, help them to regain mobility. And a lot of times, I don't know if you all seen, like in the long-term care facilities and in the hospitals, patients, they have that physical therapy or that PTA, that physical therapy aid, they come around. Um, I don't get, I'm not gonna call it name, but my family member was in the hospital, and they were in for, we'll say, low sodium. And you would have thought that, why did the physical therapist come in? Well, that was the person was critical, nevertheless, but they came in and say, hey, we're just coming in. I know you probably walk around your room, but we want to walk with you up and down the hallway. So you will see. So they were, in that instance, they were preventing the development of a complication. They were, the patient might have been walking around in the room, but that's a short distance. In addition to that, it helps strengthen that person's core. It may even burn up some calories. So when the dietitian sent the meal around that the patient selected, that they were more apt to eat it. And it's just like a domino effect. So yes, one thing does help the other, and it helps prevent the other. So it's just amazing. So let's talk what does the case manager do?
They receive like the overall information from the doctor, physical therapy, OT, and they collaborate with each other to try to find them the best care. Like once they get discharged, like do they need a nurse to come out to the home? Do they need physical therapy? Understand what their discharge instructions, see if they need anything to help them with their continued care outside of the hospital to get them to feel better.
Good. So that's a lot of moving parts. Usually this, and then everyone can have a case manager, but usually they save it for those that have like multi chronic conditions. I mean, some people even use the word complex, but they have several moving parts that are needed and need to be thought through, so this client can, be self-sufficient, or as self-sufficient as they can be. But it is discharge, upon discharge planning, that case manager is looking at, well, shoot, does this person need home health, or do they need a long-term care stay for the rehab, long term? There are a bunch of moving parts. So that case manager has to also think about, this person goes home. Okay, this person now needs oxygen. How is this person going to get, the continuous oxygen that they need? Well, may need a concentrate. They may need oxygen cylinders. How does this person actually get this? So there's several. That's why they usually say the case managers, everyone can have one, but they usually say for those complex cases, which are defined as someone that has multiple chronic conditions, that we're trying to assist that client in managing and doing well. Okay. And then radiologists, I don't think we said that. What does a radiologist do? Radiologist.
Read the images.
That's correct. So we have the x-ray technician. They actually go and capture the images. But we have this doctor that actually sits down and they read the images. They read what the mammograms say. They read what the hip x-ray shows. They actually read those images. They interpret. And then from that information, those reports are given. We're calling using our SBAR, the reason why we're calling because we have received, lab results, the X-ray results, the radiology results, and we're calling. That's our why. That's the situation. We just received the hip X-ray report for the patient in 201, and it says that the patient, has a fracture or whatever it says. And so, yes, all of these individuals, they're needed for this client to have positive client outcomes and to restore that health. And it does require all of us working together. Watching my time, you all working together. And the nice thing about it is and that wasn't a lot of the healthcare providers. We have a slide here with more on there. That was just some of them. The nice thing about it, guess who's in the middle? And they're always referring to you all, us, that the nurse. So we're sits in the middle, and we're having to help and assist those moving parts to continue. So important points. Each member of the interdisciplinary healthcare team needs to have good communication skills. Physical therapy is coming down to work with the client. The client's gone out for a doctor's appointment. Well, physical therapy could have went on to someone else and came back later in the day. So rather than just physical therapy they have their schedule. Had they known that patient in room 201 had a doctor's appointment that morning, they could have alternated their schedule so that person does not get a missed visit. So communication is very important, that they have good communication skills. Each team member must be able to anticipate problems and avoid them when possible. So be thinking is critical thinking, clinical judgment. It's just a fluid process. We're always thinking, well, what could potentially happen. So hopefully it doesn't happen. The client in room 201, they're not using their call light. It might be that we need to do more than at least every 2-hour checks on this person. What can we anticipate? Because if this person's unsteady on their feet, they're not using the call light, either because the cognition is not there or they're just choosing not to. But nevertheless, this patient is in our care and they're at risk for falling. What can we do to avoid this person from having any injuries? And this is accomplished by using critical thinking skills. And sometimes we say critical thinking, but it could be something such as changing where this patient's room is. That patient could be closer to the nurse's station. Or it could be, well, you all collaborating with the RN and saying, hey, rather than every 2 hours, we may go in and check on this person every 1 hour. We might need to, this patient keeps saying that they haven't to use the restroom. This person might need to be on a bowel and bladder training program where we go in more often to see if they have a pattern. And those are just examples of being proactive rather than reactive. But nevertheless, we must have good communication skills with everyone on that team. And just know that it can change at the drop of before I even finish the sentence. The patient, we were just down and the patient was fine. And, well, what happened? So someone said help with resources for outside the hospital for discharge. Exactly. And that's pretty much everything from A to Z. Setting up meals on wheels, or whatever type meal services that are out there. Pretty much we were talking about the case manager then. So we have 2 minutes. Let me just go back and talk about our main points. So nurses are at the center hub. So we're function as that collaborative member. We're at that center of the healthcare team. And we should provide that safe care as well. We should oversee it. So that might mean questioning orders. We want to make sure that we're using our medication administration rights. Take the time to make sure all of those components are there. But we question orders that are unusual. We make our rounds. We report those findings. Client safety is priority. Use that chain of command. If you are not getting a response from that healthcare provider, we are those clients' advocates. Ask that nurse manager to assist with getting a response from that healthcare provider. We want to clarify orders if needed. Does the order have all the components? Okay. And remember, in the midst of all this, the client has the right to refuse. So we acknowledge that as well. We want to assess the client's understanding of what they know, what their goals are, what their plans are. All of that helps establish that therapeutic relationship. We reinforce client teaching. Communicating effectively promotes patient safety. Ineffective communication is the primary cause of sentinel events. These is where someone has had surgery done on the wrong body part. Some intervention was done wrong because of ineffective communication. So we're going to pause here and take our 5-minute break. We will see you at 6:36. Remember, this recording still plays. You all turn your cameras off. Make sure you're on mute. See you at 6:36 Eastern Standard Time. What is one thing or intervention that is done to prevent illnesses?
You said what, sweetie? I'm sorry.
What is an intervention or a task or a thing that we do as nurses? We're an integral part in it to prevent illnesses. It is wintertime. That's a clue.
Hand hygiene,
And what else?
hand hygiene, vaccinations.
Vaccinations, yeah. So that's more invasive, the vaccinations part. So that is um, one thing that we actually do to prevent illnesses. Can you tell me about Virginia Henderson? Do we know who she is and what was her theory about? In the chat, do like a one liner, two liners.
You said who? I'm sorry.
Virginia Henderson. Virginia Henderson. She was a nurse theorist. What was her focus about? Her focus on? A hint would be just think about what do we do, our interventions. Virginia Henderson. So we'll give you about 2 or 3 minutes to respond to that. Virginia Henderson. Good. You all are summing it up really well. So so of course, we as the nurse, we're usually taking care of someone that is ill, or we are thinking about preventing someone from getting ill. Yes, and she looked at that component of that client being independent, whether or not we're reteaching, reinforcing those activities that would contribute to their recovery, even in death. She was looking at all of that, but those things that we could do to assist that client in being independent and being able to having the knowledge and understanding to perform those activities themselves. Okay. All right. So let's go back to our PowerPoint here. So we said each member of the team, we must have good communication skills. We want to anticipate problems to avoid them if we at all possible. Be thinking about, every time patient in room 201 starts to cough, they end up with whatever it is, just kind of think it through, see if there are any connections, using those critical thinking skills. So we talked about, I think we looked at all of these already, but we're right in that middle because they're going to be calling on us, and we should be communicating with them, getting their observations, because the patient could also be telling the social worker, the case manager, some information that they haven't shared with us. So we do want to communicate with them. We said the radiologists, they read X-rays, they give those reports, they type them out or whatever method, but so the healthcare providers use those reports to determine what are the next steps for this client. Chest X-ray was clear. There's cardiomegaly, or chest X-ray shows pulmonary edema. So based on that radiologist reading that X-ray, And whatever their interpretation is, the healthcare providers, the nurse practitioners, their next steps are based on what those reports say, based on what that radiologist reads and sees on those X-rays that the X-ray technician has captured. The case manager, discharge planning. We said home health, whether or not that's home health that's needed, long-term care, whatever resources that they need. The pharmacist, they're licensed to prepare, compound, and dispense medications. It is necessary for the healthcare workers to work together to integrate care that will provide clients with all the services they need to maintain a safe, quality, comprehensive health care. These groups of healthcare workers are called the interprofessional healthcare team. And like I said, we just named a very few, but there's so many different um, members of the healthcare team. For example, like the physical therapist, and you have the physical therapist A, we have the speech therapist, we have the speech therapy A. So there's so many people that we did not talk about that would be involved in the client's care. So continuity of care. Primary nursing can facilitate continuity of care, resulting in shorter hospital stays for clients. So think about, we have a client that is going home. They're going to the long-term care facility. That coordination and collaboration between either the caretaker at home, the client themselves, or the long-term care facility staff, that collaboration and communication between whomever is essential in that client not having to come back to the hospital because of a complication that is directly related to why they're being, the care that they have received prior to discharge. So what they're saying is they're looking at, they collected enough data that says, hey, we're just simply not communicating. Had the patient known, had the caretaker known, had the staff at the long-term care facility, had they known that this client, and sometimes it's like, well, how could they forget to tell the person that they needed oxygen at home, that they needed to go pick up the medications from the drugstore? That's what we call ineffective communication. So communication is essential for that continuity of care, and they directly related it to, if there's good continuity of care, there is effective communication. It lessens the chance of that client being readmitted for that same thing because information has been given, has been understood. Even if the person didn't understand, the person voiced, well, hey, I don't understand what you're saying I need to do. And clarification was given, it decreases the chance of that person being readmitted. So think about what is needed. Is there any medical equipment? Are there any medications? Does this client need to check their blood pressure every day in the morning? Do they need to do glucose checks? It could be, and I don't want to say it's simple, but it could be a diet that's low in sodium. So the client will know, well, hey, if I have all of my food choices at home, if they're high sodium content, I need to send someone to the store, or I need to go to the store them myself and replace that because they're saying that this increase in sodium content is making my blood pressure go up. So nothing's too small or not important to help this client take care of themselves, them, the caretaker, or even the whoever, if they're going to a facility where someone else is going to be in charge of their care. And also it increases patient satisfaction. So facilities, and you all may even do like the care maps. Some people use concept maps, but it's just so that you can look, it's a combination of the care plan and all those different critical paths. So we have a person that has, let's see, decreased nutritional intake, less than body requirements. Then we're looking at what medical diagnosis that also may be related to this client not taking enough nutrients. This client has, just had right shoulder surgery. So in their right hand is their dominant hand. So this client can't feed themselves. So they might need assistance with that meal. So care maps, concept maps is another But anyways, it's just a way of taking all the different pieces and dividing them out, but it's needed. But it's the map of the recipe. It's the instructions to help take care of this client and to think it through. Case managers keep an eye on timely discharge and continuity of care in the community by planning, directing, and evaluating care throughout the client's stay in the acute care. The strength of the case management method of delivery nursing services is its focus on delivering cost-effective, quality care to the clients with complex needs. And then quality services and cost are timely considerations for healthcare. But that continuity of care, thinking about what the patient is going to need after discharge, what needs to be said. Even if the client is at the urgent care center, what should the patient do when they return home? Is the information in the person's first language? And if it is in the person's first language, is it in terms that they can understand? Is it appropriate for what, or is the information appropriate for the person to understand and be able to act upon those instructions? And sometimes, and I know you can think back about if you've been in the ER or discharged a patient at the hospital, they give them those information sheets. I don't know if you all have looked at those, but that information is pretty much simple. Now, if you go to the pharmacist and they give you those sheets that are, uh, information about your medication, some of those are not as simple or is not as complex as those discharge instructions are. But we want to make sure that the information is adopted, or what we say appropriate, so that the client can understand it. Coordination of care as patients are discharged to rehab facilities, long-term care agencies, or back to their homes decreases hospital readmissions. Therefore, this should be the focus of the educational session. Ensure that all needed information is shared. When we're doing that handoff, when we're calling report, when we're receiving report, even if the person that's giving you report, like you're getting ready to receive the client, you're getting ready to do an admission, either at home health or long-term facility or wherever, if the person that's speaking to you hasn't given you all of enough information, ask those follow-up questions, because the focus should be information that education is going to help you provide that best care for that client. Okay. So let's look at delivery of nursing care in the acute care settings. So total patient care. One nurse plans and delivers the care. Usually this happens in the ICU. Usually we provide the total care, everything from the bath to the feeding to whatever it is. Everything is done by that nurse. That's why their ratio is a little bit less than, regular med-surg patient nurse ratio. Functional nursing. What is the task that needs to be completed? So our focus at that time is getting that task done. What is the task and what do we need to do to complete this task? Team nursing, assignment according to capabilities. The RN is the team leader. So here we would have to think about, what certifications the person might have. Is it in their scope of practice? Are they new or are they experienced? We have to consider all of that. What are their persons? That team nursing, the person will be assigned according to their capabilities within their scope of practice. And so primary nursing, 24-hour accountability, individualized client care, and accept responsibility and accountability for the total client care. It's sort of similar to the total patient care when we're working in the ICU, but to be more specific, primary nursing, 24-hour accountability, 24-hour. Individualized total patient care this may be just the 8 hours or the 12 hours that you're working, but this primary nursing is focused on that whole 24 hours. Okay. And then care or case management, care coordination within a specified time frame using clinical pathways, focusing on delivering cost-effective quality care to clients with complex needs. So any questions about this slide? This slide was kind of busy. I was going to divide it all out so we look at one component at a time. Are there any questions about what's on this slide? So the primary, so you can say total patient care and primary nursing, that we're responsible for the entire patient's care. But primary looks at 24 hours, and then the total patient care maybe just for whatever that shift that the nurse is working. Team nursing, we're looking at the capabilities of the team. What's another way we can say that for team nursing? Someone come off mute and tell us another way we can say the capabilities of each team member.
Each individual have their own role, like CNAs, the nurse, the LPN.
Okay, thank you. All right.
Collaborative.
Say that again.
Collaborative.
Collaborating, okay. Case management, we're focusing on delivering cost-effective quality care for the clients with complex needs. So remember, I told you the case, anyone can have a case management, but they usually say, they usually make sure that the clients that have several chronic disease processes, several moving parts, are assigned a case manager. Someone that has several needs, they're usually assigned those case managers. And so they help with thinking through everything. Like I say, this person might have COPD and they also might be a diabetic. So we might have to coordinate meal delivery. And then if we use a meal services, this person's going home, with that meal service be amenable to having those, rather than bringing 3 large meals for the day, can they, fix some snacks or some smaller meals? Because remember, the persons, if they have diabetes and COPD, depends on the degree of the COPD, that person, eating might not be important to them because they're trying to focus on keeping that gas exchange going, breathing in and inhaling and exhaling. But at the same time, this person has diabetes, nutrition has to be important. So all that to say that someone that has COPD, they might not be focused on that nutrition, but it is important that they consume the necessary calories to have that nice balance for the nice balance between the food, the physical activity, and medications if they're on them for diabetes. So it might mean that case manager to have and see how it can get complex, may have to have that conversation with that meal service or the caretaker to say, hey, you know, he or she might need smaller meals so that because we want to make sure that they consume as many calories as needed to sustain. And also, we don't want them to get out of breath while because of eating. So then we don't want them to choose not to eat because they're having problems with gas exchange. So everyone can have a case manager, but they're usually saved for those that have those complex needs and you have to think through those different all those different moving parts that are there. And so all of these you can be a part of. They have different settings, have different, titles and everything, but nevertheless, we're providing that individualized care for those clients. I think that is all we want to talk about on that. Okay. So client-centered, relationship-centered care philosophy. Providing care that is respectful of and responsive to, here we go, individual client preferences. Just think about it. If you are in room 201, you want things to be according to your preference. You want the nurse to know what you value, what you understand. We don't want them to break any rules or anything, but we do want them to know what we value and what our needs are. It could be that, we need, I don't know, to go to bed at 6 o'clock. And then it might take in a conversation to talk with the healthcare provider to change the times of the medications if needed. And it could be that the times cannot be changed, but we do want to consider what the client's preferences and what they value. And then we want to make sure that they have enough information so they can make that informed decision. Client satisfaction and positive outcomes occurs when client care is centered because we have taken into account what they value, what they need. And even though we might can't change what we're doing, but at least we've acknowledged, hey, I understand this is what you want or need, but this is, we're being assertive. I'm being aggressive. I'm just not going to do that. We're not going to belittle. We're going to be assertive and say, hey, at a minimum, we must come in and at least assess you every 2 hours. We understand that you said you don't want to be interrupted during the night. We might not, when we come in, we don't have to do a head to toe assessment at midnight, but we still need to come in, and there are certain tasks that we must complete. So, having that conversation equals client satisfaction and positive outcomes. More than likely, that client will be compliant or will comply with whatever task or intervention that you're trying to implement. The Institutes of Medicine originally defined patient or client-centered care as providing care that is respectful of and responsive to individual client preferences, needs, and values, and ensuring that client values guide all clinical decisions. So this is just that clinical, just a visual. We're on, be looking at those cues. The client's different. How is the client different? Well, when we went in, or when I got report from the outgoing nurse, they said this client was alert oriented times 4. When I went in at my first round, the client was alert oriented times 4. But now, halfway through the shift, on this round, this client is hard to arouse, or they're alert oriented, but they don't know who they are. Recognizing those cues and analyzing those cues. Okay, well, if I'm getting these findings, it's a change in mental status. What is going on? So, be thinking about what could really be going on. That's that hypothesis part. What can we do? The client is short of breath. They're using accessory muscle. We know the client has COPD. The oxygen, we check the tank. It's bubbling like it should. We're making sure that the tube and everything is working. We adjust the client's head of bed. We're trying to generate some solutions so that this client, to facilitate gas exchange. We've done all of that. Checking the O2 set, counting the respirations. We may have to call that healthcare provider, using SBAR, telling who we are, patient's name, why are we calling, include all that information in there that's according to the SBAR. And it's just a fluid process, you all. Is until you clock out that you are doing this, you're using that clinical judgment and critical thinking for each of your clients. Mind you now, most settings, you have more than one patient. So, so developing clinical judgment, recognizing those patterns. Remember, you all have just so much knowledge. The body system, disease processes, pharmacology, the classes of medications. So why was this medication given? Well, it was an antihypertensive. It's supposed to block, it was a calcium channel block. Well, we go in, we check the blood pressure. I checked it here at 10 o'clock, it was this. At noon, it was this. Are there any patterns? This blood pressure is getting, going up rather than coming down. Applying the concepts that we've learned. Well, in order to verify whether or not the client's blood pressure, what it is, we have to actually check it, right? So we measure it. So should we delegate? When I talk about delegation, we're ready to talk about that. Should we delegate the blood pressure measurement to the UAP? Well, as long as that client is stable, that is a task that is in their scope of practice. Measuring blood pressure, assisting with that, mouth care. These are things that the CNA can do, or the unlicensed personnel can do, as long as that client is stable. So skillful responding, reflective practice. So QSIN, Quality and Safety Education for Nurses, is an initiative that anticipates that collaboration will have a major impact on positive patient outcomes and improve quality of care. So what this does, when we talked about decreasing the number of readmissions, and they're saying simply collaborating, talking to, coordinating that care, knowing that the patient has an appointment at this time, knowing also this patient is supposed to get physical therapy, knowing that this client the norm is alert oriented times 4. When you go in and the client is less than that, there's a change. They are saying, QSIN is saying that collaboration, using SBAR to give report so that we don't leave out those critical components of nuggets of information. when we're communicating with the healthcare provider or giving report, so that we can, because that establishes our baseline. If we're using SBAR to do change of shift, that's our baseline. So when we go in, we can compare our findings with the information that we were given. Then it determines whether or not there's a change in this client. Okay, I'm gonna stop and see if there are any questions in the chat. Are we good on the information? I'm trying to break it down. I went back and redid some of our slides to just break it down to make it as we got visuals. And some of them are saying the same thing. And that's good that you're recognizing that. That means, hey, you validate what you know, and it will increase your understanding of it. Okay. Nurses act as advocates and should honor moral principles and standards and respect the client's rights to make their own choices. You know, they have the right to refuse. They have the right to accept whatever those treatment options are. The nurse should continuously advocate for the client in a professional manner. You want to be assertive, not aggressive, or not passive. And to ensure that the client is making an informed decision. We do want to make sure that client has enough information so they can make an informed decision about whatever it is, taking medications or treatment, doing surgery, whatever the intervention is. An example here, we might have to clarify questionable orders with the physician. So just because you have an order there, you want to make sure, look for that order, make sure all the components are there. Look and see if the doses are reasonable within, refer back to your drug book or your drug cards or whatever it is. Call pharmacy. Hey, this medication, I've been administering medication to this client for 4 days. This medication that's in the bin today looks different. Can you verify what you dispense to me? So call pharmacy, because even though they put it together and in the package, we're the ones that's giving it. So, they'll be reprimanded as well, but we were the ones that actually administer it. So if it looks different, because usually if it looks different, they usually put an alert, a sticker or something on it. Because, if they change manufacturers, and even if a patient goes to the pharmacy and pick up their own medications and the medication is going to look different from what they've been getting, they usually go ahead and put a sticker or some type of notification. Say, hey, your medicine, this is the same medication, but it's going to look different. So question those orders, question what's in those packages. There are some facilities that, and some hospitals do this, they pre-package whatever, what they've received as that patient's order. For example, at 8 a.m., all the patient's 8 a.m. medications are in this one package. And they have like some short names or descriptions on the packet. And so you don't see that at a lot of facilities, but some do use that. But just make sure that the description matches what's in there, because there's the thing is human error. So question it, question it, question it. This is just showing that, hey, we're collaborating with everybody, patient, the others on the healthcare team, those specialists that are outside. It does take collaboration to coordinate that care. Okay, let's look at this slide right here. It says differences between management and leadership. Management, coordinating people, time, and supplies to achieve a desired outcome in a defined area of responsibility. So leadership is the ability to empower and influence the beliefs and opinions or behaviors of a person or group by guiding, motivating, and inspiring them to accomplish common goals and recognizing their successes. So management is more focused on completing and getting that task done. Leadership, the task has been completed, but we want to ask the question or spark interest. Well, how can we have a policy and procedure here? Is it within, it matches the scope of practice, but can we do this procedure differently, or can we use less supplies? What can we do? Can we do this procedure where it lessen the time or use lessen supplies for the client? So that leadership will empower the group to, hey, let's think it through. Let's think outside the box. We want to practice in our scope of practice. And so can we, complete this task with doing it differently? It's like leadership also encompasses that spirit of inquiry. We're not practicing out of our scope of anything, but it's just thinking it through, thinking outside the box. Can we do this differently? And then leadership leads to transformation. Management is just transactional. The task was completed. But transformational, it could be that we have to revise that policy and procedure because you as a team, we've looked at it, we've eliminated step 2 and 3 because we really can do step 2 and 3 up here on step number 1. Those things are done simultaneously. And so we can transform how we are providing that patient care, which still leads to providing that individualized, safe care, best care for that client. So we do have different leadership styles here. I think I have another slide that have it all individualized. Okay, let's take a moment and look at these. So autocratic leaders make all decisions and are generally most concerned with the task to be accomplished. They maintain distance from their followers, motivating them through the overall goal or rewards as an incentive. So it's more focused on let's get this task completed. Okay. And the instructions are there specifically. Let's get the task completed. And these are the steps to get it completed. That's autocratic. Democratic involves decision making and it allows others to give their input. We come up to agreement. Of course, the task is still completed, but it involves more than just one person has made the decision, and this is what we're going to do to complete the task. Democratic involves the thoughts of others. At least we go through that process, and then we come up with a way to complete the task. Laissez-faire give followers the freedom to make whatever decision that they think will complete the task. Now, with laissez-faire, if the task might not be completed on time, it might not be completed in a safe way. So you just got to kind of be careful with laissez-faire. It depends on what the task is. Even if laissez-faire, we use laissez-faire when we're trying to do a team building exercise. We want to do the team building exercise today. Even with laissez-faire, even though we want people to have the freedom to pick and choose and bring several ideas, we still want to make sure that we get the task accomplished within the time frame. Let me stop sharing. I think a question popped up. Okay. So with transactional leaders focus on daily operations of the organization. Okay, we need these 2 patients. Their dressing changes need to be done. We need them to all have their baths. So they have to go out to the doctor's appointment, getting those tasks completed. Transformational, like we just said, inspires, intellectual, stimulate followers to recognize their contributions, to think outside the box, to think what else can we do to still complete this task, still provide the best care, but how can we do it differently? And that transformational empowers others to bring their thoughts and their talents. And then it's transactional because it is transformational because it might lead to a policy revision, which still would not, we're not going to practice outside of our scope of practice, but it transforms. And that in itself can promote and have a positive team vibe. Authentic leaders, transparent and ethical in their dealings with followers. Okay, this is what the task that we have to complete. We're trying to, our census is low. So we are, we will need to work with minimum staff. So I know we've been working with 8 people, but based on our census, we really only needed 4. So, expect to be called off or whatever, or expect to float. We're transparent about what is going on. We're clear. There's not, we're not hiding any information. Shared leaders use an approach in which employees are empowered to distribute leadership responsibilities. It's just, we're sharing the love. We're sharing those tasks. Okay. So let's look at delegation, you all. So be thinking about a person's skill set. You think about their scope of practice. We just named the CNA, the CNA patient care tech, unlicensed personnel. They can assist with bathing, they can do mouth care, they can do vital signs, they can do other things. Be thinking about the nurse. They can administer medications, IM, they can administer PO medications, they can do wound care, be tube feedings, just be thinking about the correct task, the right task. Delegated tasks must conform to the established guidelines. We don't want to ask anybody to do anything that is outside their scope of practice. And unfortunately, it's going to be on you to know what's in your scope of practice, because sometimes people will ask you, your nurse manager, your charge nurse, they may ask you to complete something, a task that is not in your scope of practice. So it's on you to know. And for you to also know, don't delegate a task that's outside of the scope of practice of who you're asking. So the nurse is responsible for supervising patient care to ensure that it's completely delivered. Why am I saying that? Because even though we delegate a task, we're still responsible. We're not relieved of that task, of making sure that task has been completely delivered. The nurse, we should consider when we're delegating, consider the knowledge and the skill set that's needed, or the competency of the team member. We want to consider the patient. Are they stable, unstable? We want to consider the needs of that patient. What task will be delegated? We have this patient that has several things that need to be done. Excuse me, but are we going to delegate all the tasks, or just as one? Are we just talking about delegating one task? When a task is being delegated, again, what is the skill set? What is the experience of the person that we're delegating it to? Is this person new? Or are they experienced? Have they passed off on their checkoffs? We want the care to be provided safely, efficiency, in an organized way. Okay, so right circumstances. Delegated tasks do not require independent nursing judgment. Okay, so like we talked about the blood pressure measurement. They can measure, they'll get the measurements, but the person shouldn't be discussing, well, this is high, this is low, this is probably considered hypertension, this is considered hypotension. Is this client stable versus unstable? Right person, decide who is qualified and competent. Is this a skill set? Is this in their scope of practice? Have they completed their checkoffs? Because a person could have been just hired. The name tag says, unlicensed personnel or CNA, but have they been shown competent in that facility to complete that task? Okay, or do we need to select another person that's working that night or that day? The right directions and communication. Ensure that what we're communicating is clearly explained about the task and the outcomes, and when the delegatee should report back to the LPN. We want to clarify the time frame and expectations. We want you to measure the blood pressure every 2 hours, but be specific to say at 8 a.m., 10 a.m., or whatever those time frames are. Once you get those measurements, I need you to report back to me what they are after each measurement, or at the end of the shift, or after you've taken the first 2 sets, whatever those directions are. And then the right supervision and evaluation. Feedback to assess and improve the process. Evaluate the client's outcomes. So remember, we're not relieved of our duties because we have delegated. We are not relieved of those duties. We must still go in and make sure that the task has been completed. If a task is delegated, the nurse is relieved of that task. Is this true or false? If a task is delegated,
False.
the nurse is relieved of that task. That is false. The nurse retains responsibility for the client care, even though they delegated a task to a stable client that was within the UAP's skill set, and their competence level. But the nurse still retains the responsibility of that client care. The nurse must ensure that the care has been provided. Example, making rounds to see that the care has been provided is the best method to evaluate the care, on your rounds or in between your rounds, but nevertheless going to see, well, hey, was this task completed? Before you delegate, the client must be assessed. Data gather on their condition, a CNA or UAP, unlicensed personnel, cannot delegate to another UAP or CNA. The nurses can delegate. Delegation cannot be transferred. This UAP says, hey, well, I'll swap this task with you. It can't be transferred and they can't delegate. It's only the nurses that delegate. The delegatee can refuse delegation. We ask, well, hey, why are you refusing to complete this task? You never know. Have a conversation. For proper delegation, the function must be accepted. So just because you delegate, we want to confirm that the person is accepting and not refusing to complete the task. Using the nursing process when assessing tasks or delegating. You can't get away from that nursing process. It's really our friend. It helps us to get through, think through everything. Use that nursing process. The nurse is responsible for supervising patient care to ensure it is competently delivered. When delegating tasks, the nurse must take into consideration the skills and competency of the team members, as well as the condition and the needs of the patient receiving care. This person needs two persons. This person may just need setup help. This UAP or CNA, they're new, they've just started, they haven't completed all of their competencies yet. Supervising the patient care delivery. We must still supervise the patient care delivery. We should determine the skill mix of the unit personnel. That's simply saying, we have 5, personnel working with us today. 2 are new. 1 has completed all their competencies. So they're still in their skill set is a little different, or their level is a little different. So we can assign these patients to this one. So you being that charge nurse will have to, you have to think through, even when you are assigning the patient care, because you have to determine the skill mix, the competency level of the person that you are assigning those patients to. You want to assess the needs of the patients involved. So you want to make sure those clients walk around and make sure they're stable versus unstable. Because even if the skill set, the person has the skill set, if that client is unstable, we wouldn't delegate or give that care to that unlicensed personnel. And then, of course, we have to decide which task to assign to a team. And this takes a while. So if you're that charge nurse, you come in at whatever time, because you have to go through all this, decide what the mix is for the unit personnel, decide, how many patients, which patients. In certain facilities, they may have assistance with this, but you have to think it through so that the best care is provided for those clients, because you want to keep the patient safe and you also want to keep, the staff safe, the nurse and the unlicensed personnel safe as well. All right, so here it is. We got a slide here. Can the UAP or the CNA do the following? So we're asking, is this action inside or outside the scope of practice? So if it's inside the scope of practice, we would say yes, the CNA or the UAP can do the following. And if it's outside of their scope of practice, we would say no, they cannot do the following. Okay. So assist with the bed bath. Can or cannot?
Yes.
Yes.
Okay, or yes or no? Okay, good.
Yes.
Can.
Okay, I hear yeses and I hear can. Okay. Measuring blood pressure.
Yes.
Yes.
Okay. Discuss the results of the blood pressure measurement with the patient.
No.
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 Okay. Apply a wound dressing.
No.
No.
Discuss and formulate nursing diagnosis.
No.
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 Okay. Apply compression devices or stockings. And some places
No.
have like the
Yes.
device,
Yes.
and then some have those
Yes.
stockings. Okay.
Yes.
Take and place orders. And we're talking
No.
about physician's order.
No.
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 Okay. Assist with setting up a sterile field.
No.
I only have one no. Can the unlicensed personnel CNA assist with setting up that sterile field?
Yes.
Assist, are they gonna be with a nurse or RN?
Yes, they can, I
Yes.
think.
Yes.
No.
No, they cannot assist with setting up that sterile field. Because remember, that's one of your checkouts. More than likely, it's one of your checkouts in your labs. But no, they can't not assist with the sterile field. What about? So again, we're clear they cannot assist with set up a sterile field. What about administering Tylenol as ordered and reassessing?
No.
No.
Good. Okay, so we're gonna take a little pause here. And let's do our second 5-minute break. We do have, more time at the break. We'll push it at the end. And then we will also get in our groups, our week 10 groups. So let's just take a 5-minute break here. And so we'll see you back at 7:29. 7:29. Remember, this recording still plays, you all. All right, so I am going to pause the recording. So everyone should be back in about 45 seconds. Let's share here. Okay, if you were to give a statement, I want you to take the time to type this one in the chat. Give a statement that best describes the focus of nursing practice. Think about all those things that we do. We're coordinating, we're collaborating, we're providing, uh, giving medications. We do so many different things. Give like a one statement that best describes our focus of the nursing practice, and just send it out so that everyone can see your responses. If we had to sum it up, one statement, what would that give us? A statement that best describes our focus. Let me set my little timer. We'll give you about 2 minutes to type that up. I'm gonna stop sharing for just one moment. I'm gonna share it again in just a second. Someone is not on mute, you all. Make sure that we don't hear anything that we don't need to hear now. Check your mics. Make sure you're on mute. So you're typing up a statement that best describes the focus. If we were having to sum it all up in one statement, all those things we do, what would we say? See what your responses are. Share them out to the group. See what you put in the chat. 52 seconds left. Share it out to the group. To ensure patient safety. Safety first, using critical thinking to implement safety, being compassionate. Okay, our little time is up. To ensure patient care is met by ensuring safety, consistent care, and advocating for patients. To ensure patient care is being met. So yes, you're being that client advocate. You're providing that individualized, unique, client-centered, and you're collaborating with those on the healthcare team. And it does That's our focus. It's like, well, we do all these things, but if you narrow it down to that, that's what we are focused on. Okay, good. Thank you for sharing. Let's go back. Just a couple more slides. This one. Okay, what information, you can come off mute and tell us this. What information is given first when contacting the healthcare provider? Remember the tool that we're going to use, and then remember those components.
The situation.
The situation,
And what does that
You're
include?
gonna identify
the current
yourself.
onset of the
You're gonna
patient.
identify yourself and the patient, and what room the patient is, and what is that patient problem.
Okay, someone else. She said patient, yourself, patient room. Someone else, tell us what information you're going to give them first.
You're gonna address yourself in the current onset situation of the patient with the patient name.
Okay, did we get it all? What is the reason for the call? We're going to include our name, the unit, the patient name, and the problem. I think we got it all. Good. What information are we going to give them second? Come off mute.
A little bit of history of the patient, the background of the patient.
Okay. What else?
The vital signs and what is the patient allergic to. Is they have any allergies, and you want to address their co-stats.
We get it all. So admitting diagnosis, date of admission, their current status information, which includes their vital signs, medications, allergies. So why is it important to give their allergies? Why do they need to know that?
So the doctor won't prescribe nothing that they're allergic to.
Exactly. IV fluids and their cold status. Good. Okay. SBAR is that tool that we use to, to guide us so that we can tell everything that needs to be told. Okay. The nurse is responsible for supervising patient care. We're gonna use the chat for this one. Patient care to ensure that it is competently delivered. List 4 things that this would include. The nurse is responsible for supervising patient care to ensure that it is competently delivered. What things should we be thinking about if we are going to be delegating and assigning patients? So list 4 things, place it in the chat. I'm gonna go on mute. Let me put a timer on. It's 2 minutes. One minute, 20 seconds left. There's 4 things that we should be thinking about considering when we are supervising patient care. All righty. Wait a minute. Did I lose you all? Oh, I thought the Zoom had closed you. Okay, so patient safety, pain level, having the UAP report back to include the information on the timers up, direct clinical treatment, the patient's rights. Okay. Okay. So the nurse is responsible for supervising patient care to ensure that it is competently delivered. So we have, what concept is there? We have patient care, and then we have competently delivered. So we want to make sure that the person is competent. Well, how are we going to know what patient care the patient needs? So we have to go in and we have to determine that. We're going to look and see, is the patient stable, unstable? This person needs one person, two persons. We're going to look at the care plan. We're going to look at all of this. Then we have to match that piece with the person. Is this my skill? Is this within my skill set? If I'm an unlicensed personnel, am I new? Have I passed all my competencies? What is my skill set? And then we want to, we want me to be able, we don't want to put me in any conditions or settings where I am going to do something that's incorrect, that I can't do, I'm not supposed to be doing. So when delegating tasks, the nurse must take into consideration the skills and the competency of the team member, as well as the condition and the needs of the patient that's receiving the care. We want to, at a minimum, we can do a whole bunch of things, but at a minimum, we want to supervise the patient care delivery. Because remember, even though we are delegating this, we're assigning it, it does not relieve us of our duty to ensure that the proper care has been delivered. We want to determine the skill mix of the unit personnel. I'm new, I'm experienced, I passed all my competencies, or I passed all of them but two. So those two competencies that I haven't passed, I should not be doing those skills. I should not be performing those skills or conducting those on anyone. So if the patient in 201 needs for example, blood pressure, if I haven't checked off or mastered or got certified with blood pressure, I shouldn't be assigned to go take that person's blood pressure. And then I want to assess the needs of the patient involved. What all does this patient need in room 201? Does it need to be two persons when we're turning repositioning? So we have the main person assigned, but then we also have an additional person when we need to do transfers, turning repositioning. Deciding which task to assign a team member. Okay, good. What should the nurse do? A coworker has taken the debit card of a patient and used it to make a purchase. What you can come off mute. What should that nurse do?
Report it to the
it.
supervisor.
Okay, report it to the supervisor. All right, good. What should the nurse do? Coworker has taken one pill of the patient for themselves.
Report.
Report it.
Report it to the supervisor.
What if you really don't know that they took that one pill, but that one pill is missing or several pills are missing? We haven't confirmed, but we have a suspicion.
You still have a right to report it.
I guess when you check the patient, see that she took it or did she misplace it by putting it in her pocket, ask her about it.
So we still need to report it. And then that's where the supervisor will do that investigation, because it could have been, because I don't know, once you get to, working, some of those in some facilities actually have keys and you have to put them in your pockets, and you just get a habit of putting things in your pocket. I don't know about putting pills in your pocket, but you just get a habit of putting things in your pocket. So that's where that supervisor, we report it to the supervisor, they will do that investigation. And because remember, we don't want to do anything that's not on our task list and it's on the supervisor's task list to do that investigation. So we report it to them. And of course, they'll ask. They'll have them to write their statement. And it could be that, hey, they dropped it and disposed of it without getting that second person to witness it or whatever the situation is, but we must report it. Okay? True or false? Appropriateness is achieved if the communication is, I think that should say not. That looks like an M. is not well adapted to the people and situations it involves. Is this true or false?
False.
False.
Okay, I hear false. I heard several falses. Do we have anybody that disagree? Is this false? Remember, remain on mute, you all, if because we're recording. Is this false or true? So far, we hear false. Am I hearing any true?
It's false
I think
because
it's
it's
true.
not. I think it's false because it's not communicated and it's not done appropriately. I'm thinking
Okay.
false because it's not
Because it's saying that it wasn't
communicated properly.
Yeah, you can't deliver appropriate care or effective care if communication is not understood or adapted to whoever is involved and whoever else has to be involved.
Okay.
Okay, so is that supposed to be not or met?
It's not.
Oh,
It's
okay.
not.
So not, okay. I'm thinking it was misspelled or something.
It was misspelled. It says not. So test taking tip. That one word can change things because at first we were reading appropriateness is achieved. It's a communication, but that one word that's misspelled, not changed this whole thing. So remember, the entire answer choice has to be correct. So in order to make this true, what word do we need to take out or change?
Not.
Okay.
Need to change that to met.
Appropriateness is achieved if the communication is well adapted to the people and the situation it involves. Because this is simply saying that we are providing individualized, unique care for our clients. So if we take out the word not, so test taking tip, make sure you read through the entire answer choices, the entire scenario, and make sure that you're answering or make sure that you're not missing any words. But yes, this is said not. So that one word made this thing false. But we're providing appropriate care if we're providing unique. We've talked to our clients, we've established those therapeutic relationships. We see what values they have, what preferences they have. We are being assertive. We are being honest with them. We're telling them, hey, we have to come in and check on you at a minimum every 2 hours. And so that communication appropriateness is achieved because we've communicated to the patient. They've communicated to us. We have not been aggressive. We have not been passive. And we're providing that unique individualized care to our clients. Okay. Communication competence in nursing requires that communication be both effective and appropriate. Effectiveness is achieved when the goals of communication are met. Appropriateness is achieved if the communication is well adapted, unique, individualized to the person that's receiving the care. Okay. All right. And so that brings us to our end. So we're going to take our last break, which takes us on out. We will make sure that you go back through this recording, last week's recording. Exam 2 is next week. Take care. Stay warm. I think everybody's cold everywhere. Stay warm.
Will you be updating the slides to this PowerPoint?
You just have to watch the recording. That stuff I put in there, that's not that's just stuff I just be adding in. I be making up little stories and scenarios and misspelling words. Look, and misspelling words. So that's just something I do. So just make sure you go back through the recording.
Okay.
Therefore, you also have the explanation and you hear the discussion behind.
Okay. So this exam 2 PowerPoint is just going into a little bit more depth what you said.
Yes.
Okay. Thank you.
Because I like to give the people the scenarios and all of that stuff just to apply what you all already know.
Okay. And thank you.
You're welcome. You all rest well. Stay warm.
Thank you. Stay warm.
Thank you.
Thank you.
Will we do another exam review or they